This is where the light comes in from the pupil, from the exterior, through the pupil, through the lens, and then it forms an image on the retina, and the electrical impulses are then transmitted via the optic nerve to the brain, and we see the image. So it's a very sensitive layer present at the back of the eye, and I will show you the different regions of the retina. If something goes wrong in the retina, it's going to have a profound effect on your vision. Behind the retina, we have the layer called the choroid. If you can see here in the diagram, this is your retina basically. Here is your optic nerve coming out. This is your lens in the front, and the pupil, where the light comes in through the pupil, gets reflected by the lens and comes here. This is the center of the retina, which is called the macular area. The image is formed here, and then the impulses go via the optic nerve to the brain. The choroid layer is a very vascular layer which is present behind the retina. And behind that, we have the sclera, which is a thick fibrous coat that protects the eyeball. This is another view of the retina. Here we have the optic disc. These are the retinal vessels coming out. We have the arteries and the veins. The main artery is called the central retinal artery, and the main vein is the central retinal vein. And then these are the branches. So we have branches coming out superiorly, inferiorly, temporally, and nasally. This part that I'm showing you over here, this is the center of the retina. It's called the macula. Right in the center of the macula is the fovea. This is the most sensitive part of the eye, where you have the maximum numbers of rods and cones. It's responsible for your color vision, your near vision, your fine vision. The rest of the retina also has rods and cones, very few cones. Cones are mainly here. It is the rods basically here. So this is for our peripheral vision. And for the night vision, more rods will help you during your low light conditions. So this area, if any pathology affects this area, it's going to cause a profound loss of vision. I'm not going to discuss the optic nerve pathologies here. When we examine the retina, we can also see anything happening to the optic disc area, and that is a separate topic. We will discuss all the common conditions that can affect our retina. And as you all know, if something goes wrong with the retina, if there's a permanent damage in the center, we cannot replace the retina. Work is being done abroad about retinal transplants, retinal chips, and you might have heard of the bionic eye. All that is being done. They're using technology to put in subretinal implants, but we're still far off from that. So our basic aim is to prevent disease occurring in the retina, and if something has occurred and we cannot prevent it, for example, age-related macular degeneration, then we try to slow the progress of the disease. So what are the common retinal diseases? We will come to that in a few slides. Before we start that, whenever you're seeing a patient, how do you examine the retina? Because when you're a medical student and you come to the eye ward, you will probably just see patients that you're examining on the torch. Very few of you will be using ophthalmoscopes. If you're bright enough or interested in it, you can ask the resident to teach you that. It's not difficult, but basically we don't expect you to go into all the different technologies that we have and the different machines. But for your knowledge sake, if any of you are interested in going further, these are the ways we examine the retina. So this machine here that I'm showing you in this photograph, this is called the slit lamp biomicroscope. We call it basically the slit lamp. So what happens in the slit lamp is the patient sits here, the doctor sits here, and there's a chin rest here, the eye is placed here, and it's basically a microscope. We can see the interior segment details very nicely there, the iris, the lens, the cornea, even cells in the interior chamber. But to look at the retina, we need to use this special lens, which is called a 90D diopter lens. This will focus the light rays on the posterior part of the eye, and we can see the retinal details here. So very commonly in the eye department, in the OPD, we are using the slit lamp. The second machine, you could say, or ophthalmoscope that we use is called the indirect ophthalmoscope. This is also very commonly used. It's placed on the head, and the ophthalmologist is examining the patient from a distance using a lens, which is called a 20 diopter lens. This technique allows us to examine the retina in its entirety. You can see the complete periphery. You ask the patient to move the eyes above, below, left and right, and you can see the patient completely. The only drawback is that the image is inverted. So you have to realign your brain to figure out that this is an inverted image and laterally reversed. In the present time of COVID, this is an ideal technique to examine the patients because you don't want to come in close contact with a corona positive patient. This is the direct ophthalmoscope. Many of you have seen this in the pictures, I guess. Probably you have not seen it in the eye ward or eye OPD because we don't use it at all. This is mainly used by the medical ward, by the physicians, if they want to get a quick look at the retina. We don't use it at all. Different reasons why we don't use it. You get a very small view of the retina. You basically will see the optic disc and you will see the macular area, and you don't see the periphery at all. The second thing, as you can see in the picture, the ophthalmologist has to come very close to the patient. You see, he's almost touching that patient's face. So we have two reasons not to do it. One is cultural. A male doctor will not want to come so close to a female, or a female doctor will not want to come so close to a male. And now in the present time, this is completely contraindicated in the times of COVID. And the third thing is you will get no view if you don't dilate the pupil. So these are all the difficulties. Even with the indirect, you have to dilate the pupil, but the main two reasons are that we don't want to come into close contact and you're getting a really small view of the retina. So we don't use it, but you need to know this is a direct ophthalmoscope. So you get a direct image. The image is not inverted. Okay, now what are the other methods that we use? We can use a B-scan ultrasound. So this is a picture showing the probe on the eye. The eyelids are closed. You can do it over a closed eyelid or even on the direct on the cornea. And we can see an ultrasonic image of the back of the eye. So if there's any pathology like a retinal detachment, there may be a foreign body, there may be a tumor, we use ultrasound. This is a picture showing the fundus photography being done. So we have this machine in our center, and a technician can take images of the patient's fundus and he can send it to the doctor or give it to the patient in the form of a CD or email it. So this is good for telemedicine, which we are doing a lot these days. The third machine here is called the OCT. So the OCT gives you an image of your retina in microns. It's like a CT scan basically of the retina, and this is showing the foveal area. So this machine is also in our center. We have top of the line OCT, and we use this for every retinal pathology. It's a really useful technique. So coming back to now, what are we going to discuss? So the common retinal pathologies that I have broken it up for you are, you see congenital diseases. We have a lot of trauma in Pakistan and especially in JPMC. 24/7 we're dealing with traumatic cases. So that they also involve the retina. You can have infective diseases, vascular diseases, very common. And as you all know, number one is diabetes mellitus. So I would say 70%, if not more, patients coming to our retinal clinic are of diabetic patients. Then you can have neoplastic conditions, and lastly, degenerative conditions. So I'll just briefly show you some pictures. I'm not going to go into a lot of text to bore you, just show you pictures so you get an idea. So what do we see in congenital disorders? So a common thing that we do see is congenital toxoplasmosis. And toxoplasmosis is caused by a parasite called Toxoplasma. There's a spelling mistake, Toxoplasma gondii. A patient can get this by eating raw or uncooked meat, milk, or if they're exposed to cats. And usually a woman who's pregnant will catch this disease, and then the child is born with congenital toxoplasmosis. They can also have brain defects, calcifications, child can have epilepsy, but the main thing is that they get these macular scars and they go undetected for a long time. And when the child goes to school and is unable to read the board, then they come for a checkup and we find that the scars are affecting the macular area. The rest of the retina is normal. So if the patient has a scar in the center, the central vision will be low and the child will not have good vision. And this sadly cannot be reversed. See, this scar is a permanent scar. In adults, we can get acquired toxoplasmosis. So this would come under infective. This previous scars that the person is born with can get reactivated and cause retinitis, or it can be not a reactivation, a pure acquired toxoplasmosis. Usually you see this in immunocompromised type of patients. So if you have an acquired retinitis, we treat it with antibiotics, and there's a whole regimen how to treat. This can get better, but still scars, if left in the macular area, causes permanent visual loss. If there's a scar in the periphery, it may not affect your vision. The second disorder, which is inherited disorder, this is not like you would not say a pure congenital, it's inherited. It's due to the chromosomal pathologies. You can have autosomal dominant, autosomal recessive, or X-linked recessive. This is also quite common in our population, mainly I think because of cousin marriages. So what happens is that person is born in a family, there are 2 or 3 family members already affected in the previous generations, or the siblings may be affected. And gradually, as a child grows up in the teenage years and young adult years, they say that my vision is going down. I can't see from the sides. The patient is maybe falling down the stairs or cannot drive. They cannot see in the periphery. So these are the sequence of changes that this is your normal vision. Then your vision starts coming down from the periphery, and then it becomes a total like a tunnel vision that you can just see through like a pipe. And then eventually there's total blindness. So this is the pathology of the rods and cones, and you know that that's very important for the image to take place, this processing of vitamin A. So in a very advanced case of retinitis pigmentosa, you will get these findings in the retina, and these black scars are called bone spicule type of lesions. You will get a waxy pallor of the optic disc, and the vessels will be very attenuated. So currently there is no effective treatment for this condition, but like I told you earlier in the lecture, work is being done with retinal implants and different other artificial intelligence technologies. So maybe in the future, these patients might have some hope to restore some vision. So depending on the inheritance, autosomal dominant have a less severe, progression of the disease, and those with X-linked recessive have a very severe prognosis. So this is very easy to identify when a patient comes to you. You just look at this picture of the retina, and it's easy to diagnose that this is due to retinitis pigmentosa. Then the second category is your traumatic. So what we see is commonly in our OPD, patients coming to us with vitreous hemorrhage. Patients coming in the emergency come with intraocular foreign bodies, and the retina clinic where we do the most surgery is for retinal detachment. So one by one, I'll show you some pictures about these conditions. So what is vitreous hemorrhage? Vitreous hemorrhage is when there's blood in the vitreous cavities. So usually the vitreous is a clear transparent gel. You can see the optic disc and vessels. But when there's blood, it can be of various degrees. The whole vitreous can be full of blood and you see nothing. It's all like a red reflex. There may be small amounts of blood or maybe localized. So there are different categories of the vitreous hemorrhage. Common causes, like I told you, are trauma. You may have vascular disorders. The most common we see is with diabetic retinopathy. Then we have vasculitis and disease called Eales disease. So what do we do for the treatment? First of all, we're going to investigate, is it just vitreous hemorrhage or is there a retinal detachment? For that, we do the B-scan ultrasound to see if the retina is okay or not. The retina would be flat if it's just a vitreous hemorrhage. And you can see that on the B-scan because you cannot use the direct ophthalmoscope, indirect ophthalmoscope, or the slit lamp when there's blood there. You can't see anything behind. So if there's a small amount of blood, we can just observe the patient and have the patient sit upright so the blood settles with gravity. If it's a large amount of blood and it's not clearing, then depending on the underlying conditions, if it's diabetic retinopathy, we give injections. These injections are called anti-VEGF injections. Okay, these are vascular endothelial growth factor anti-VEGF. That means it's anti-vascular endothelial growth factor, and these clear up the leaking blood vessels from the retina. If that doesn't work, then we would have to do a vitrectomy. So we go and do surgery and we take out this blood and the vitreous gel and clear it up and then treat the underlying retinal pathology with laser or any other method. So this is another picture. Now this one is showing a very localized vitreous hemorrhage, but this is under the hyaloid face. It's a premacular or subhyaloid. So the rest of the retina is clear, but it's leveling off. You see that due to gravity, the blood is come down. So the patient will not see because it's covering the foveal area, the macular area is covered. So either we observe it for a week or two. If it doesn't clear, then we can use a YAG laser. With a YAG laser, we make a hole here at the bottom and the blood will drain out into the vitreous cavity. If there's still a lot of blood, it's not draining out, it's very thick, or there's a membrane, then we can go for vitrectomy and clear up this blood. Because if you leave it there and it's not clearing, it can cause wrinkling of the macular area and the patient will have permanent visual loss. Now coming to retinal detachment. Retinal detachment is a common pathology. We see this all the time. It can be spontaneous in very highly myopic patients or in patients who've received a minor head trauma, or in older patients who have underlying retinal pathology. So the patient presents with sudden floaters in front of the vision. There's a painless loss of vision. The patient says that I feel like there's a curtain falling. It depends on where the retinal break is. So you will have different presentations. The surgery is an emergency surgery. If you leave the retina detached for weeks or months, then you will be able to reattach with surgery, but your macula will be disturbed. The macular function will go away. You are disrupting all those rods and cones and all the nerve endings. They will never be restored. So the patient may not have more than 6/60 vision. If you do the surgery within 24 hours and your macula is still attached, you can get almost 6/6 vision. The different surgeries we do for retinal detachment is a scleral buckling, which is an old procedure. Not many people do it, in which the retina is, the hole is sealed off, and then you put a band around the retina. The current treatment we do is pars plana vitrectomy. We repair the detachment and we seal the hole with laser, cryo, and then we put an air, gas, or silicone oil tamponade. So this is a picture showing a large retinal tear. This is the retina, and you see the underlying choroidal reflex when the retina tears, and you see that the whole retina has lifted up. So you know that the retina has two layers. So this is the upper layer has lifted up, all the fluid has gone in and causes ballooning of the retina. So when this is lifted up, the patient will not see in that area. This is another picture showing a superior retinal detachment. This is the lower retina, the retina is still attached. This is the macula, it's attached. There's a hole somewhere up here. So this, if we operate on this patient right away, we will preserve this macular vision and the patient will still be able to see well. This is another picture. The retina is totally detached here. You see that the surgery has not been done yet and the retina has come off superiorly, inferiorly, temporally, and nasally. Now, this is a picture showing the superior detachment here, and that's the same picture. And then there's another picture in which there's an inferior tear and the retina is detaching inferiorly. So the inferior detachments, because of gravity, they can remain undetected for longer periods of time. So all these need to have a surgical repair. Another type of retinal pathology is a macular hole. A hole can occur right in the center of the macular area. The rest of the retina is all attached. So this is an OCT showing this disruption here. Common causes are trauma and old age and even myopic patients. So for this, we would do a vitrectomy and we would remove the vitreous, take out the fluid from under the macula and put in oil, gas, or even air. Now, the next pathology is an intraocular foreign body. We commonly see people who are hammering with a hammer and chisel. They get a sudden feeling that something went into their eye, and then they come with a sudden loss of vision. They may have anterior segment pathology, they may have a corneal tear, they may have a lens disruption, but commonly the foreign body comes at a very high speed. It's usually metallic and it goes and settles and sits on the retina. It may be floating the retinas, but commonly we see it on the retina. So now to get this huge foreign body out, we have to do a vitrectomy and lift up this foreign body with a magnet or take it out with forceps. And then if there's any break underneath of the retina, we will seal it with laser. So this is something we commonly see, but when the patient comes, sometimes the patient forgets the history. There may be a very small corneal disruption that heals, and it's difficult to localize it. So you have to do a few tests when the patient comes. So like I've told you before, the B-scan ultrasound can show you anything inside the eye lying on the retina, like this opacity here. And here also we see that the retina is lifted here. So this is a retinal detachment, and there's a foreign body. Then metallic foreign bodies, they show up on the CT scan. You can see this shadow over here, this radio opaque, this is the foreign body. This is another axial view of the CT scan, and you see this foreign body. This is a picture of the intraocular forceps to hold it and bring it out, or we can also use an intraocular magnet. One thing to remember, we never do an MRI in an intraocular foreign body because MRIs, they have magnetic fields and the foreign body is metallic. It may move with an MRI, and that can cause a lot of damage within the eye. So we always recommend either CT scan or a B scan or a plain skull X-ray can pick it up also. Now, the next topic is the vascular disorders. So things you may be asked in the exam are, what happens if the central retinal artery becomes occluded? The central retinal artery is the main artery, and then it branches into superior, inferior, and different branches. So if it gets occluded, which is usually by an embolus, your patient may have a carotid pathology, the patient may have atrial fibrillation, and clots are generated. These will go into your central retinal artery, and they can block the blood flow. So this is another emergency. The whole retina will become pale. There's no blood flowing, so it becomes edematous. It becomes white, and the macula will, the fovea media will be red. It's showing the underlying choroid reflex. So this is called a cherry red spot. There are other syndromes which also have cherry red spot, but for the vascular disease, this is the main one. So if you, I mean, there's not much you can do for these patients. The ambulance may get disrupted by itself if it's small, or you use different techniques called carbogen therapy. You make the patient breathe in a paper bag with 95% carbon dioxide, and you try to disrupt the clot. So if that goes within 6 hours, the blood flow may be restored and the vision can come back. But if the whole central retinal artery is occluded, there'll be a permanent loss of vision, and you'll end up with optic atrophy. If it's in one of the branches up here, there will be just a segmental loss of vision just in this area, and the central vision will be preserved. So whenever a patient has a central retinal artery occlusion, you must investigate the cardiovascular system. There's always some underlying pathology going on. Why are these clots being generated? The next one is a retinal vein occlusion. We commonly see this. A thrombus forms in, or an embolus forms in the central retinal vein or one of the branches. Here we have the inferior branch vein. So the inferior temporal branch vein, that got occluded, and you see multiple hemorrhages on the retina. And this causes a loss of vision in this. Whenever you have a retinal pathology, the loss of vision will be opposite. If it's the inferior, you will have field loss superiorly. If it's temporal, you'll have field loss nasally. So because this is inferior, the visual loss will be superiorly. But the rest of the retina is normal, so the rest of the field will be normal too. Main causes are hypertension, diabetes, and hypercoagulable states. And this is another one. This is a total central retinal vein occlusion. You see all the scattered hemorrhages all throughout the retina. So this is a more serious type. And we classify this into ischemic and non-ischemic. With ischemic, you can get permanent visual loss. Non-ischemic, sometimes the vision is restored. Treatment, you have to treat the underlying diseases that are causing it. You can give anti-VEGFs to bring down any macular edema. And then if there is ischemia, you can even do laser later on to prevent neovascular glaucoma. So the common complication of an ischemic vein occlusion is neovascular glaucoma. Now, the most important disease which you will be asked in every field of your medical college journey, diabetes. And we are discussing diabetes retinopathy. So we divide this into two, non-proliferative and proliferative. In non-proliferative, we get background retinopathy. You may have hard exudates, hemorrhages, and cotton wool spots. And all of these can present with macular edema. With proliferative, you get new vessels because there's a lot of ischemia. in the vessels. The blood flow is disrupted, so there's hypoxia, so new vessels generate. This may lead to vitreous hemorrhage and traction retinal detachment. This is a picture of a non-proliferative diabetic retinopathy. These yellow dots are the hard exudates. And if it goes near the foveal area or the central macula, the patient will have macular edema and the central vision will go down. So we treat this with anti-VEGF injections. This is a picture in which we are seeing the new vessels forming. This is proliferative. In this picture, you see proliferative. This is a cotton wool spot. Cotton wool spots are also called soft exudates. These new vessels, they are leaky. So they can bleed at any time and cause vitreous hemorrhage, like the pictures I showed you in the beginning. And we have to do surgery or give anti-VEGFs to bring down these new vessels because there's a lot of ischemia in the retina. This is an end-stage patient who was not treated adequately, and you get tractional retinal detachment. The hemorrhage organizes into fibrosis, and the retina becomes pulled up at various. We can still treat this with a retinal detachment type of surgery, vitrectomy, but obviously the extreme ischemia is going to affect the vision. We don't want our patients to end up like this. We want to treat them in this phase or very early this phase, and that is done by repeated follow-ups to the retina clinic, repeated injections into the eye, and laser. Laser is very, very important in preventing these things. So we do so much of therapy for diabetes mellitus that I have a lot of pictures. These are one of the injections that we use. This is called Lucentis. It's an anti-VEGF. These type of branded injections are very expensive, over ₹1,00,000 for one injection, and patients may need 10 to 12 in a year. So you can see how expensive it is. We have a cheaper version, which is called Avastin, which is used off-label. That's around 3,000–4,000 rupees, but that is not a branded. We make it from the pharmacy at AKU or Shokathanam, and we put that in the eye. This is the technique of injecting the anti-VEGF into the eye. This is a picture of our retinal theater, and we have top-of-the-line vitrectomy and microscopes. We record everything, and we're operating on these patients all the time. There's a picture how we make the ports, how we go inside the eye and operate on them. This is another diagram to show you the injection. And the injection is always done through the pars plana part of the retina. So that will not cause a hole. The pars plana is the area where the retina doesn't break up. If you inject down here, you may make a hole. This is a picture showing a pan-retinal photocoagulation. We use an argon laser and we laser the whole retina. And when you laser the retina, basically you're burning out the retina. And this causes decrease in the release of VEGF. When VEGF goes down, so the new vascularization goes away because you're burning out the ischemic areas. So this is a very sort of vision-saving treatment. This is another close-up photo of the argon laser photocoagulation. And this is all, we have top-of-the-line lasers in our department as well. Now, and another pathology is hypertensive retinopathy, and hypertension as well as diabetes, both are very common. So depending on the level of the blood pressure, you can get these findings like retinal hemorrhages, cotton wool spots, and attenuation of the vessels. In extreme cases, when there's a condition called malignant hypertension, when your blood pressure is over 220, and by 120, you might get edema of the disc. So that's one of the differential diagnoses for papillary edema. You get disc edema, a lot of macular hemorrhages, and the patient is in a bad shape. Now, our next topic is neoplastic lesions. Let me tell you, in adult patients, we don't really see neoplastic tumors or malignant tumors of the retina in adults. Mainly, we see them in small infants or neonates. In adults, we usually see metastatic lesions to the choroid underlying the retina. So discussing the neoplastic lesion in a child, retinoblastoma is a very, very important cause of leukocoria. Leukocoria means a white pupil. And in our population, sadly, we get to see retinoblastoma almost 1 to 2 or even higher cases in a month in our department. And we usually see these cases in families of lower socioeconomic status, because they don't get their children probably checked up early on. If they're noticing anything wrong, they will ignore it, and they usually come in very late stages. If you're living in an advanced country, or you are here in a higher socioeconomic sort of a group, you will come immediately to the doctor if you notice something wrong with your baby. So this is a very important cause of leukocoria. You can have it unilateral or bilateral. The bilateral cases usually are heritable. That's why we see it in the interior of our provinces where there's a lot of current cousin marriages. So whole families get affected. We have seen families with all their children, and sadly they come so late that they don't survive. In the Western countries, not only the child survives, but the vision is also preserved. So this is a white pupil reflex. It can be in both eyes or one eye. The patient may present with a squint because the patient is not seeing from this eye, so the eye might be deviated. Or in our setup, we can come with a huge mass coming out of the eye. So this is a retinoblastoma lesion. It's usually chalky white, and it shows calcification on the CT scan. It's calcified. So we need to get all the investigations. You do a CT scan, you do other abdominal ultrasound to look for mets and other different investigations, treatment. This is an advanced case that we usually see in our ward when it's really grown out of the eye and perforated. And like I said, this is very unfortunate because you can save the eye if you come in an early stage. And not in the government setup, we never see people coming early, but in the private setup, we've saved the vision of many babies because they came on time. So what we can do is that we can do a laser around the tumor if it's small, like going back to the previous picture. If this tumor is small, so you can go and do a laser here, or if it's in the very periphery, you can do a cryo, which you can freeze it off, and it will regress and form a scar, and the child will survive. Depending on the stages, if laser and cryotherapy can't be done, then you can do localized radiation called brachytherapy, which a plaque is put on the eyeball, and radioactive iodine is given, and that will shrink the tumor. If it's huge like this, you would have to, this stage would require exenteration. That means everything comes out, all the muscles, all the orbital fat, just bone is left. Enucleation is done in a lesser stage in which the eyeball is removed with the optic nerve. And if it's really advanced, then you have to radiate this whole area. So that is something that we want to avoid. We want to treat them in this stage, the early stages. But commonly what we do is enucleation and exenteration. So like I told you, in adults, we don't get retinoblastoma or other retinal tumors. We see metastatic lesions, not too commonly, but we have seen them from time to time. These are under the retina in the choroid. As you know, the choroid is a very vascular lesion. So through the bloodstream, mets can come and reach here. The difference between a primary tumor is mets usually affect both retinas, and they can be multiple. So CA breast, CA lungs are common. This is a picture showing mets from a CA breast. And this is a choroidal melanoma. This is usually primary, it's usually pigmented, and this can be a primary tumor of the choroid, and it presents under the retina like this. Now, coming to the last condition, degenerative, age-related macular degeneration. You may have heard or read about this a lot. This is a very, very common disease in the Western world where the population lives beyond 90 and even 100 years. So if you go abroad, you will see all the people who are 85 plus, they wear dark goggles in the sun, and they're going to the ophthalmologist repeatedly. They're getting multivitamins, they're getting all the tests because this disease is very, very common there. And they want to preserve their central vision as long as possible. In our country, we don't see it that much. We do see it, but not to the extent that we see in the Western countries, because our people don't live that long. I think that is the main reason. If you reach 70, you know your life is done almost. People sadly don't reach 90s, 100s here because of different reasons. So how do the patients present? They start gradually getting a central loss of vision. It's very slow. It takes years and years and years. And they will not be able to see the center. They can't read the numbers on the clock, or they can't see the features on the face. And it can start in one eye first, but then gradually goes to both eyes. Usually starts after the age of 65. We have two types, wet and dry type. Wet type means is edema, leakage of blood, leakage of fluid. Dry type means is just degenerative lesions called drusens here, which are like lipid deposits, and that causes atrophic lesion. there's no leakage, but it becomes dry and atrophic and really thin, the macula. And the wet one is leakage of blood and fluid. So for the wet one, we can give anti-VEGF injections to slow the progress. That will dry up the blood, but the disease cannot be cured. And when it's a dry type, we give low visual aids like magnifying glasses or other visual aids like close-up laptops, large prints, so that the patients can function. So for the wet, like I told you, we'll use anti-VEGFs. So that comes to the end of this lecture, and I